Do you ever have a patient with shortness of breath and wonder if it is due to heart failure or COPD or any of the other multiple diagnoses in your differential? Have you had difficulty determining the etiology of a patient's AKI as pre-renal, renal, or post-renal? The solution to these tough questions can often be helped with point-of-care ultrasound, also known as POCUS. As healthcare providers, we often encounter cases where a quick and accurate diagnosis is essential, but the information we need is not readily available. This is where POCUS can make all the difference. With its portability, versatility, safety, and real-time imaging capabilities, POCUS is becoming an indispensable tool in many medical specialties. Welcome to our Beginner's Fundamentals of Point-of-Care Ultrasound. In this video, we're going to delve into medical ultrasound and explore the physics, the knobology, probe selection and orientation, and vocabulary that you need to know to get started with POCUS. Whether you're a medical student, a resident, or a seasoned clinician, understanding these basics of POCUS is essential for providing high-quality patient care. So let's get started. You may ask, what is ultrasound? Humans are able to hear frequencies between 20 Hz and 20 kHz. Any frequency less than 20 Hz is considered infrasound, and any frequency over 20 kHz is called ultrasound. Medical ultrasound is at frequencies between 2 and 18 MHz. Now, to show you how images are generated, electricity powers the probe. When this electricity comes in contact with piezoelectric crystals that are in the probe, the crystals change their shape and form ultrasound waves. The ultrasound waves are directed towards your subject, and some of those waves are reflected back. The probe, which was a transducer in providing ultrasound waves, now acts as a receiver. It takes the ultrasound waves and converts it into electricity that is then seen as pixels on your screen. With advanced technology, the images are now much better. We're going to talk briefly about some elementary physics of ultrasound. As I stated, when you point your ultrasound probe toward your subject, ultrasound waves are reflected back, but they are also scattered, refracted, absorbed, producing heat, and then also transmitted through your subject. All these properties of ultrasound affect your image. After the probe emits the ultrasound waves, it tracks the time it takes for the reflection of those ultrasound waves. This helps in spatial orientation. An object near the probe will reflect the ultrasound waves more quickly, and as a result, the image will be at the top of the monitor. When the ultrasound waves come in contact with an object farther from the probe, the reflection of those waves will take longer to return to the probe, causing the image to be displayed at the bottom of the screen. Now to define some characteristics of a wave. Amplitude is the height of the wave. This makes your image more or less intense. Wavelength is the distance from a point on the wave to the same point on the next wave. As you can see from this figure, there are two waves. The first wave has a short wavelength and the other one has a longer wavelength. This is important because it's related to frequency. Frequency is the number of wavelengths per unit time. The official equation is frequency measured in hertz is the propagation speed of sound divided by wavelength. But really what you need to know is that frequency is inversely related to wavelength. As you can see in this drawing, the short wavelength has more wavelengths going through a period of time as opposed to a larger wavelength. So when you have small wavelengths, you're going to have a higher frequency, where if you have a long wavelength, your frequency is going to be lower because you're going to have less wavelengths in that time period. Resolution, or the fine details of the image, and penetration, which is the depth of the image, are related to frequency. Resolution increases as the frequency increases, but the penetration decreases with increased frequency. These characteristics of resolution and penetration and their relationship to frequency helps determine the best probe to use for your exam. A low-frequency probe is going to have a lower resolution but a higher penetration than a high-frequency probe. And a high-frequency probe is going to have better resolution but less penetration. Here are 3 examples of probes, 2 that produce low-frequency ultrasound waves and 1 that produces high-frequency ultrasound. The linear probe, which is the high-frequency probe, is commonly called a vascular probe. Because it has better resolution, it is a great probe to use when cannulating or examining a vessel. Resolution is very important in this case because the clinician needs to know exactly where they are with respect to the vessel, but since the vessels are typically superficial, the penetration or depth is less important. Now the 2 low-frequency probes, they have low resolution but high penetration. They are used more to examine the chest, abdomen, and pelvis. So as you can imagine, the penetration is more important so that you can see more tissue, and the exact resolution is less important. Although both these probes are low frequency, the curvilinear and phased array are different in some respects. The curvilinear probe is often known as the abdominal probe. Because it has a wide footprint, it is used in the abdomen and pelvis more frequently so you can see more tissue. The phased array or cardiac probe is also low frequency, but because of its small footprint, it's ideal for examining between the intercostal spaces. It also has a faster frame rate, so it detects the motion of the heart better than the curvilinear. You can use these different probes in different circumstances, and as you become more accustomed, you'll be able to determine if resolution or penetration are more important, and that will help you decide which probe you want to select for your particular exam. When you look at images, you can determine which probe was used by looking at the shape of the image. For curvilinear pictures, they will look curvilinear from the top to the bottom, where a linear probe will produce a picture that is rectangular. The phased array is kind of in between, where it starts out with a straight edge and then is pie-shaped with a curvilinear image at the distance. There are 2 types of POCUS. First, there is procedural ultrasound. Using ultrasound guidance when doing procedures, such as putting in central lines, paracentesis, thoracentesis, or pain procedures, has been shown to be more comfortable for the patient since the proceduralist is able to be more accurate and does not require as many attempts. Ultrasound guidance for procedures is now the standard of care for most procedures because of better accuracy and less complications. Diagnostic ultrasound is becoming more popular in multiple medical disciplines because it can help the clinician arrive at an accurate diagnosis more quickly and can monitor the effects of therapy with multiple POCUS exams. We are going to focus on diagnostic ultrasound in this video. Diagnostic ultrasound has 3 components. First, you have to be able to acquire the image, and then you have to be able to interpret the image, and finally, and most importantly, you have to be able to integrate that image interpretation into the clinical picture of your patient. To acquire an image, you have to be familiar with knobology. Knobology is learning how to use the knobs on your ultrasound machine. When you're trying to get an image, there are 3 knobs that you have to use. First, you turn on the power, choose your probe, and then choose your preset. To optimize the image, there are 2 other probes that you have to work with, the gain and the depth, to make your picture look the best. After powering on your machine, the first choice you make is to select your probe. You choose the probe based on the attributes of the probe's frequency as we just described. Then you choose your preset. These machines are becoming more and more intelligent and are able to help you optimize the image. So if you pick a cardiac preset, you're going to get a better view of the motion than if you pick a lung preset. Gain is the other knob that you're going to need to know, gain and depth, to optimize your image. When you see a video, if you increase the gain, it becomes more white. Gain is the brightness of the picture, and you can see by increasing the gain that the image is no longer good. If you decrease the gain, you have to be careful not to do it too much, or you'll lose a lot of the image. It's like Goldilocks. You don't want too much where the picture is whited out, or too little where it's too dark to see the images. You want it to be just right so that you can see a difference in the different echogenicity of the different tissues, so you can delineate what you're looking at. You want to put your image in the center of the screen. That way you can push an auto gain button and the machine will help you with the best gain. If you want to adjust it manually, there are ways to do that on each machine. The other knob you need to use is the depth button. You don't want the depth to be too much so that your image is not at the center of your screen for optimization. You don't want to have unnecessary tissues in your image to distract you from the important exam. On the other hand, you don't want too little depth or you will miss important details that will be out of your image. You want to adjust the depth to be the best balance of enough area to see your exam, but not adding too many extraneous tissues. Depth is usually easy to adjust up and down. As you gain experience, you'll have a better idea of how deep you want your images. Orientation is another important factor. It's kind of like a video game where you need your hand-eye coordination. So the probe has a marker on it, and there's a screen marker so that you can orient yourself. There's also two different types of conventions as to how to place the probe marker. There's the traditional radiology one as well as a cardiac one. Every probe has a marker, whether it is a knob, an indentation, or a painted mark. You need to know where the probe marker is on the probe that you are using. When you are using the traditional radiology convention, you will want to point the probe marker to the patient's head or to the patient's right. The cardiac convention is different, and we will describe that when we are examining the heart. Here you see the probe marker and the screen marker, and that helps you orient yourself with your hand-eye coordination. The radiology traditional ultrasound marker will be on the left of the screen, and the cardiac will be on the right. Finally, we need to learn the vocabulary so we can communicate how to acquire and interpret the images. We will discuss probe movements, planes of view, and echogenicity. For probe movements, there's 4 basic movements. There's sliding, where you go back and forth or front and back. There's rotating, where you go around the axis. Rocking, where you rock it along the long axis. And fanning is when you tilt it along the short axis. So when you're looking at images, you do a big sweep to get into the general area, and then you make these small movements to get exactly where you want. Planes of view are important because you need to examine your image in 2 different planes to make sure you're not looking at an artifact. As you learned in anatomy class, sagittal view divides the body into left and right. Transverse, on the other hand, is cutting through the body so that you have superior, inferior, or cranial versus caudal views. And coronal goes through the body, so you have an anterior posterior or ventral dorsal. And these are important for you to know how to look at each image through different planes. Finally, the last vocabulary is describing our image. When you see black, it's considered anechoic, and that's usually due to fluid. However, on the opposite side of the spectrum, when it's very bright, it's called hyperechoic. Here you'll see the diaphragm is brighter than the area around it. Isoechoic is when all the density or echogenicity is pretty similar. So in this picture, the liver shows a pretty smooth echogenicity. And then finally, hypoechoic means it's not as black as anechoic, but it's less intense than surrounding tissues. If you look at this cortex is hypoechoic as compared to the hyperechoic calyces of the kidney. In conclusion, understanding the physics, knobology, probe selection, probe orientation, and vocabulary of POCUS is essential for mastering the valuable tool in modern medicine. With practice and dedication, you can become proficient in using POCUS to improve patient outcomes and enhance your medical practice. So keep learning and keep practicing, and POCUS will make a difference for both you and your patients. I hope you enjoy POCUS as much as I do.